Good evening, everyone. It is Movember. It is a month for men's health. And tonight we have a men's health webinar hosted by Dr. Wade Muncey. Tonight we're going to cover the signs, symptoms, and treatment options for erectile dysfunction and stress urinary incontinence. This is an interactive presentation that you're able to ask questions anytime during the presentation this evening. So to do that, I ask that you're going to tap your screen of your mobile device or move your mouse. There's a toolbar that will pop up. You're going to see one tool that says chat. Type your question into the chat box that's there, hit submit, and then at the end of Dr. Muncey's presentation, we will get to those questions. I feel very lucky that we have Dr. Muncey here. He is a urologist, a men's health specialist, and a passionate educator. And he's going to cover all this information in depth and answer your questions. So without further delay, I'm going to hand the mic over to Dr. Muncey and let him present.
Great. Thanks for that, Mike. Well, thanks for everybody for coming. Yeah, I'm going to talk about erectile dysfunction primarily, but I'll cover a bunch of other stuff too, like Peyronie's disease and testosterone and all that stuff. And I'm happy to answer questions on all that as we go. This is just a quick slide about a little bit about my background if I haven't met some of the folks, but I'm originally from Spokane, but I've been kind of all over for training. I went to University of Washington for med school, and then residency was out in Cleveland, Ohio, at Case Western. And then I did fellowship in men's health, which is mostly prosthetic urology and infertility, testosterone, things like that. Everything we're talking about today down at Stanford. So I guess the first thing to answer is, what is, erectile dysfunction? And in my opinion, erectile dysfunction is basically whenever you're unhappy with the erections that you're getting, potentially that's erectile dysfunction. Either you're not maintaining it or you're not even able to obtain it. Like obviously that is a problem and leads to some stress. It's a, super common problem. About 50% of men by the time they hit 40 are actually dealing with it already to some degree. And it's easy for me to remember because it goes up stepwise through the decades. So 50% by 50, 60% by 60, it's very common. There's even men like under 40, about 25% of men are dealing with erectile dysfunction. So it's a huge thing. What exactly, how do erections actually happen? Well, basically on a kind of simple level, you have nerves that go down to the penis, and when you're aroused, they basically stimulate the smooth muscle in that area, and it causes them to dilate and allows blood to come in. The blood fills kind of these, the center part of the penis. If you're looking at the screen, that looks sort of spongy with the holes in it. The blood comes in there, and it actually compresses as it expands the veins on the outside of the penis so that the blood and effectively kind of gets locked into your penis. And so when you have problems, one of those two things could potentially be going on. There's a nice just little picture of how it expands, obviously. So what are the causes of this? The most common causes are the things I listed here, vascular, diabetes, medication, or result of prostate cancer treatment. And I think a lot of guys are kind of shocked to find that, if you've had stents in your heart, if you've had a previous heart attack, if you had a previous stroke, like things like that really play a role. I have lots of guys in my office that, they had to have stents put in at some point in their heart, and suddenly, boom, they have erectile dysfunction. So that's a huge thing. Diabetes leads, and I'll talk a little more in a second about that, but diabetes is a huge thing that leads to this. And obviously prostate cancer treatment, and I'll spend a little more time talking about that as well. Obviously, if you have erectile dysfunction, it's going to affect you in a negative way, as everyone here could imagine. So first off with diabetes, diabetes is a huge problem. Fortunately, it's actually slowly improving with these new drugs that are coming out like Ozempic. That's been a huge game changer, but men with diabetes are less responsive to like conventional therapy. So like things like Viagra and Cialis. And basically the reason for that is it actually affects the nerve endings in your body. That's why when you have diabetes, if you go to your primary care doctor, they're going to say, let me look in your eyes, let me feel your toes, all that kind of stuff, because you get what's called neuropathy, which if anyone is listening who has diabetes, they're very aware of that. Well, like I mentioned before, these small nerves that go down to your penis, if those become neuropathic in a sense, you're gonna have problems. You're not going to get erections very well. And this is just another slide kind of saying that the nerves are very important. That's why, it can affect these small nerves, right? So things in your eyes, things in your fingers, and all that kind of stuff. So that's why Viagra then doesn't really have a platform to work because the your nerve stimulation is damaged. Other factors, and I already kind of talked about this, but there are some medications that can lead to ED. Like a common one is like beta blockers, so metoprolol, propranolol, sotalol. And then advancing age, I already mentioned that briefly before, but I tell patients, time is undefeated in all this. Like as you get older, you're going to have more problems. And we can talk about why that is if anyone has a question about that. We do know that erectile dysfunction is a risk factor for future heart disease. So especially when you have a young guy in his 40s who's coming in with erectile dysfunction, it's sort of red flags that, is there something on the horizon for him, related to his heart? Like what are the lifestyle factors going on? How much alcohol does he drink? What's his cholesterol? So a lot of these, like for my patients that are younger, it's important to like, do you have a primary care doctor? Are they looking into all these things? Because it is an early symptom of heart disease. I kind of tell patients, your penis is basically a glorified blood vessel. So if there's something wrong with that, you can imagine there's more things wrong internally. And this is kind of just a sampling of kind of like what blood vessels look like and how, even a little bit of obstruction from calcifications and things, something called atherosclerosis, related to cholesterol, you get less blood flow. So obviously, for erectile dysfunction, there's lots of like, before we even talk about medications and treatments and all these things, the things that are easy lifestyle changes that can be helpful are, obviously the things that your parents told you to do, eating right, exercising. If you get the blood pumping more, cardiovascular health, you're more likely to have better erections. Weight loss is helpful. Smoking is a huge one. A lot of guys don't realize that smoking leads to erectile dysfunction. I've had lots of patients who have not wanted to stop smoking because they're like, yeah, if I get lung cancer, whatever. But I tell them, hey, this is probably a big part of why you have erectile dysfunction. Suddenly they're willing to quit smoking. And obviously stress plays a factor. I think, back in the day, people used to say, oh, erectile dysfunction, it's all in your head. Well, we don't really think that. And I don't tell patients that anymore because it doesn't seem to be totally true. But for sure, if you have a lot of stress in your life, maybe sex is on the back burner. So what about testosterone? I see tons of patients for low testosterone. And, this is a super common thing. For men over the age of 40, testosterone goes down by about 1% every year. And there's certain risk factors for this, right? Obesity is probably the biggest one. And the reason for that is that the more fat cells you have in your body, the more of an enzyme you have, which is called aromatase in your body. It lives in the fat. And so basically your testicles make this testosterone and it immediately gets chewed up and turned into estrogen. So when you lose weight, suddenly your testosterone goes up. Talked about some of that other stuff already. And I won't spend a ton of time talking about this, but happy to answer questions. But there's lots of treatments for low testosterone. Gels, patches, oral meds, injections, something called Testapel, which are little pellets of testosterone. And I do think it's important, like someone coming in with newly diagnosed low testosterone and erectile dysfunction, I usually will check a testosterone if that's not been done before. Even if they're not having like all the classic symptoms, fatigue and libido and stuff, because there's data that, if you have low testosterone, actually pills like Viagra and Cialis don't seem to be as effective as men that have normal testosterone. So what about prostate cancer? Obviously, this is super common and just baseline stuff. Prostate cancer is one of those things that is in the cards for a lot of men. And if you think about 80% of men, 80 will develop prostate cancer in their lifetime. So waiting room of 10 guys, that's 8 out of 10. Now that doesn't necessarily they have something that needs treatment necessarily. Like a lot of prostate cancer, we can just monitor for long periods of time and it's totally fine. But for men that do end up needing therapy for higher risk categories of prostate cancer, basically options are things like radiation and surgery. The most important nerves that go to your penis that assist with erections are actually underneath the prostate. So you can imagine if you're removing the prostate, you're going to be damaging those nerves, at least to some degree, hopefully just a temporary. And I see lots of patients for something that I call penile rehabilitation to try to get their erections back. But the window of time after a prostatectomy to help with erections is basically a year. You don't get as much improvement after that first year. It kind of plateaus. So I'm pretty aggressive in that first year when I see men after that surgery to try to help them. This is just a little diagram of that. So obviously there's a huge swath of guys, but I would say most men have some issues with erectile dysfunction after a prostatectomy. And that's just the way it goes. You're working around an area where there's important nerves. The biggest predictor of who is going to do better after surgery is guys that had really good erections going into surgery. If your erections are kind of heading into a prostatectomy, they're definitely going to be a lot worse after that. Kind of just pushing along here. Peyronie's disease. I see a lot of this as well. And just for just some background information too. Peyronie's disease is super common. It affects about 1 out of 10 guys. Some sources say maybe 2 out of 10. And it's been around forever. It's been around as long as there's been humans. We used to call this Vikings disease because it's more common in folks with Scandinavian ancestry. But the most the common symptom as people show up is that they say, hey, I noticed that I have this penile curvature, and there's a lot of trying to rationalize, well, how did this happen to me? And sometimes there is a story like I was having sex and I pulled it out and I went back in really hard and something happened. But for most guys, it's almost just like out of the blue. They just suddenly have this curvature, and it's obviously just stressing. One of the side effects, not just the curvature and potentially painful erections, but that is just erectile dysfunction. Obviously, if you have a part of your penis that has this scar tissue, sort of like blowing up a balloon, if part of the balloon doesn't expand very well, you're not going to get good erections. And a common complaint is, I feel like it gets hard up to a point and then it's soft right after that scar tissue. So clearly that's not great. Good news is there are lots of treatment options. I won't get into all the details about this, but I talk to guys all day long about this, but there's non-surgical and surgical options basically. And we should just kind of do what, I think whatever the people feel comfortable with, but usually most people start with non-surgical stuff. So what about these things? I get asked a lot about this because there's a lot of kind of like pop-up shops along the road that are kind of hawking this stuff. And and there's radio ads, and it's sort of like, what is all this? What are all these things for erectile dysfunction? And I feel bad when I have guys that came in and said, I spent, $5,000 at this place with shockwave therapy, or whatever, however amount of money, and it didn't do anything. Because, in our body of our governing body, American Urologic Association, we call these things investigational because, we don't know that they work very well. And there's a couple studies that show they definitely don't work very well, like stem cell therapy and PRP, platelet-rich plasma injections. Those clearly don't work. Shockwave has some data that it may, but it's definitely not the golden ticket to fixing the problem. And actually, for men that have an undiagnosed Peyronie's disease, like if no one ever took a good look and saw that, it actually makes it a lot worse, and that's pretty clear. So I'm pretty hesitant on these things, generally speaking, but happy to talk about that. So these are the treatment options, well, some of them maybe, that most people are familiar with when it comes to erectile dysfunction. Oral medications, injections, vacuum devices, urethral suppositories, and implants may be less familiar to folks, but I think it's becoming a more common, it's in the vernacular more commonly now, I think, all these other things, but we'll go through them all. So oral medications, what is this? These are things like Viagra, Cialis, Avanafil, Levitra. You've heard these names. How do they work? Well, in the simplest terms, they do increase blood flow to the penis. They're called PD5 inhibitors, so phosphodiesterase 5 inhibitors. That's just a molecule that basically stops the erection. So you're giving yourself something to stop what normally wants to make your erections go away. So it keeps them going. And they work pretty good, at least for a time. They definitely work well. They can be affected by food. You definitely need to time it. I tell men, you got to take an hour or two before intercourse. It works best on an empty stomach. There are side effects for sure. Headaches is the most common one, or people say they have back pain, or facial flushing where their face feels warm, because it's dilating blood vessels in your penis. but it's also dilating blood vessels in like everywhere else, so your face. But I do think these are great. I think they're very safe. There's some data that they're actually maybe cardioprotective too, meaning that men who take these are more likely to not get, have cardiovascular events in their future. There's even some emerging data that potentially these medications prevent the onset of Alzheimer's. I mean, this is new stuff, but it's pretty encouraging data. Intracavernous injections. So what does this mean? This is usually for men that have already tried medications and that clearly is not working. So this is another option that I talk to guys about. It's basically a medication that you drop in a syringe, and you inject it into the side of your penis, and we teach you how to do this so you don't do it incorrectly, because obviously there can be problems with that. And it basically inject it in and it gives you erection within 10, 15 minutes or so. But despite that, it works pretty well. But historically, and I see this in my own practice, most men don't continue it for very long. Most men on the order of 2 to 6 months, they're like, I don't know if this is for me. The reasons are usually things that you could imagine, like it hurts. They don't like that they have to keep it in the freezer. Then they have to kind of plan everything around and get a needle into their penis. It does cause some scar tissue, for sure. And over time, it leads to more and more scar tissue. So you end up needing higher and higher doses because there's less spongy tissue, kind of like that first slide, in your penis for the medication to act on. So that's one of the downsides. It's also contraindicated technically, and people do it, but technically for people with Peyronie's disease. So they already have scar tissue. You can imagine you're putting a needle into that area, you're going to get more scar tissue. Anyway, so in a nutshell, we'll talk more about that. What about the vacuum device? I think this paper that we wrote here sort of overstates this. I think most men don't enjoy this. Number one, it's the most common complaint that I get is this doesn't feel like a normal erection. It's basically a vacuum pump goes over the penis, you pump it up, blood gets sucked in, and then you kind of pull the penile ring back along the shaft to keep all that blood in there. Most men say that they feel like their penis is wobbly, kind of like a wobbly penis after this. Trouble ejaculating is a common thing. And in my mind, this is a great thing, not necessarily for erectile dysfunction, but it's really good for guys that just had a prostatectomy and they're really hoping to maintain the length that they have lost after surgery. Happy to talk more about that, but that's part of my penile rehabilitation program that I have guys on. Because, after a prostatectomy, part of your urethra, which, travels through the penis, travels through the prostate, and goes to the bladder, part of that's been removed and it's kind of been put back together. So you can imagine your penis has effectively got pulled inside of you. So the vacuum is great to help kind of pull it back out, so to speak. We'll talk more about that. Urethral suppositories, most guys don't like this, to be honest with you. Number one, it's very expensive. And number two, you have to take the medication sort of like a little gel pellet and basically insert it into your urethra. So it's something going up your penis. A lot of guys have a lot of pain with that. Some people feel dizzy. So when I have men that do this, I'm like, hey, you got to lay down on the bed before you do it. I don't want you to be standing up, bending over, and passing out. But most common reason in my mind why people don't like this is because it hurts and it doesn't work. I'll spend some time talking about this now because I think this is not something covered very frequently, like in a primary care visit. And even in a lot of urology offices, if urologists aren't comfortable with this surgery or don't do a lot of them, they feel uncomfortable even talking about it. So what is this? Basically, this is called a penile implant. And it's sort of, if nothing else is working, or they're just people are unhappy with the things that they're doing. So you're on injections and it's working, but you're like, man, I don't like sticking a needle in my penis every week. Then this is a good solution. So basically, the way that I would describe this is it's fixing sort of the problem that is causing the erectile dysfunction from a mechanical standpoint. So normally what's supposed to happen is obviously blood comes into the penis, it expands, and it compresses those veins. If you're having erectile dysfunction, then clearly that's the problem. That's not happening. So what we do is we basically replace the inside lining of the penis with these hollow cylinders. And then we basically place a small device inside the scrotum that's connected to a reservoir of fluid that's in the pelvis. So you don't feel that, but it's deep. And when you want to, and there'll be a video in a second, but when you want to have an erection, you basically press on this device in the scrotum and it pulls the fluid in, expands the penis, and gives you an erection. So, clearly that's a good thing. You can get an erection whenever you want. It lasts as long as you want. So, and you can, put your erection away when you're finished. Yeah. And so, common side effects, I wouldn't say common. In fact, the thing that I'm most worried about is infection risk. And for a guy that does not have diabetes and does not smoke, or they have diabetes and it's not, and it is well controlled, infection risk is actually only about 1 or 2% now, in kind of the modern age, which is really good for a surgery, in my opinion. Mechanical malfunction, again, super rare, 1 or 2%. And from a satisfaction point, people are generally really happy with these, especially if they've tried and failed all this other stuff. There's 3 main types of penile implants. Definitely, in my practice, I primarily place 3-piece inflatables. There are 2-piece and there are malleables. The 3-piece definitely dominates the market. It's the most natural appearing, natural feeling. I think it works the best, but there's a role for these other things. So the 2-piece generally, like in my mind, the only time I've done this is when there's something going on with the abdomen that makes it hostile in a way, like if they've had a kidney transplant or something that I don't want to place, slide the reservoir back there, you can get a 2-piece, but I don't like them quite as much, but it is an option. And the malleable implant is a little different too. It's not inflatable. It's sort of like filling the space inside of the penis with these rods that are bendable. And so basically when you want to have an erection, you can just bend your penis up and it's firm. And then when you're finished, you can kind of bend it down and it's out of the way. The great thing about these devices, the Boston Scientific devices, is that they are also, to help prevent infection, coated with antibiotics. So rifampin, and not that anyone cares, but rifampin and minoxidil. It's great. It helps reduce infection. And when everything's deflated, I tell guys, there's lots of guys at the gym that have these things. You just don't know it. I noticed because I'm a urologist, but you look just like anybody else, basically, if you were walking around. Yeah. So let me show you this little video here. We'll just watch it quickly. I won't narrate through it. I'll just let it play. No sound, so kind of awkward, but it's just squeezing in. I'm deflating it. There's a button to deflate it, like one quick hard squeeze. It all goes back. So a question I get asked, well, how is this done? How does all this stuff get in there? So basically, I tell guys it's like not too dissimilar from the incision you get from a vasectomy. It's a little bit bigger, but generally it's one small incision on the scrotum. And we kind of place the device through that. And most people are able to start using the device in about 4 weeks. Some people take 6. It just depends on pain tolerances and swelling and things like that. Everyone's a little different, but the goal is that at 4 weeks, back in action. Another common question is, what does this cost? And the good news is about 70 to 80% of insurances do cover this for men that meet criteria. So that's nice. And Medicare covers this. The VA covers this. So yeah, it's a good option. And Boston Scientific has financial assistance too, which is great. Let's get through some of these here. And I kind of already talked about this, but I say, about 89 to 90% of them are still functioning at 10 years. I mean, I've had people come in when just started having problems with it 25 years later, and which is great. And I kind of liken it to, if you buy a new car, if you drive the heck out of that car, at some point you might have to replace the tires or spark plugs or something. But generally speaking, most of them are still functioning 10 years. So obviously the benefit of this is you can have sex whenever you want. There's no medications involved. Um, Another great website that I like, because there's a lot of patient videos and people just talking about their experience, is something called edcure.org. It's a great website to take a look at. I tell people to check it out. Okay, I'm going to transition over to stress incontinence, and I'll explain what that means. But basically, stress incontinence is when you cough, you sneeze, you bend over, you're lifting something, and you leak. So urine's leaking. Um, and a lot of men have this problem, but I would, definitely it happens more commonly after some sort of prostate surgery, aka like a prostatectomy. So you can imagine if you lose your prostate, which is sort of like a cork on the whole system, you have your bladder, your prostate, and your penis takes off from there. If you lose your prostate, you definitely lost the cork. And as men, we don't really learn in our lives to control our pelvic floor muscles very well because we've never had to. Our prostate kind of does that for women. Obviously, they don't have that. They're very keen on their pelvic floor. They do Kegel exercises after they give birth, and they're used to like training their pelvis to not leak. But for men, you lose your prostate and suddenly you can be pretty incontinent. I kind of already talked about this, but any sort of pelvic trauma, um, even if you've had surgery like for BPH, like occasionally I've seen guys that have incontinence even after that, like a TURP, like a TURP or any of that stuff. So leakage can happen. And the good news is though, after prostatectomy, most men after like the majority of men after the first year of surgery do get better. They aren't leaking as much or at all. So that is great. And I can attest that I see a lot of guys with this problem. And, if you're leaking a lot, you can imagine why you'd be depressed. You're spending a fortune on pads. You have to change your underwear all the time. At night, when you're totally relaxed, you wake up with urine everywhere. It's a pretty, you know, distressing problem for men to have, especially when they have a partner. And it's just a lot. There's another thing, I don't think I'm mentioning this. Yeah, I'm not mentioning this here, but there's another problem that can happen too called climacturia, where when you ejaculate, actually urine comes out, which no one really loves that. Um, so again, this is sort of just going all back to what I said before, but prostate cancer surgery can lead to incontinence, and it's the same reason as I mentioned before. We're cutting all these nerves that supply the neurovascular bundle that supply your sphincter muscles, your urethra, and we're disconnecting the bladder and putting it back together. So clearly, there's a time where the nerves are sort of stunned and it's easy to leak. So what are the things that most men try, especially initially? What I call timed voiding, where guys like, every hour or every 2 hours, they just go to the bathroom just to keep the volumes in their bladder low so they don't have as much leakage. They kind of dehydrate themselves a little bit, especially before bed. Some of the best stuff that, especially after surgery, that works really well is pelvic floor physical therapy. So that's basically seeing a trained professional who will teach you specifically how to strengthen those sphincter muscles, like things like Kegel exercises are one of those ways. But anyway, yeah, another option is pads and adult undergarments and things like that. The issue with all this stuff, you can imagine, and I have a lot of guys that'll tell me this, is they're spending a ton of money on pads. Like they're not cheap, and the costs do add up if you're going through, like you have guys that go through like 20 pads a day. They keep them stocked in their car, keep them, everywhere because they're worried about going out in public. And it gets really expensive. So what options do you have? So for men that, I would say have mild to moderate stress incontinence, there's a nice solution called a male sling. Basically, what that is, and this picture kind of shows, it's basically like a hammock. It kind of goes underneath the pelvis through the obturator frame, which are these large openings in the pelvis, and they kind of put pressure on the urethra to kind of hoist it back up. And that little added bit of pressure helps many men stay continent. It's a pretty minor procedure to have done. It's outpatient. It's kind of no bells or whistles, just the sling goes in and that's it. Um, but like I said, it's for mild to moderate, and moderate I'd put with an asterisk. So it's not for everybody. And I think, for the right patient, this is a great solution. However, anybody who has leakage, if they want, especially for men that have significant leakage, you can get something called an artificial urinary sphincter. Definitely improves men's lives, undetectable, and it is kind of like having a healthy sphincter. So what exactly is this? It's a nice photo on the right here, but basically it's a cuff or a balloon that goes around the urethra and it sort of compresses on the urethra. So that way, you're in effect, you've kind of blocked off the urine from able dripping out. Then there's a little device, little button, basically a pump inside of your scrotum that you can feel, but it doesn't look any different from the outside, but you feel it. So basically you show up to the urinal, push the button, the balloon deflates, you're able to pee all the way out, and then the cuff automatically reinflates. You kind of sit there until suddenly, boom, the dribbling stops and you're done. So it simulates normal voiding, I think, the best of all these other things. So let's see. Quick video of this. Disclaimer. So you can kind of see that button there with the balloon around the urethra. So basically push the button and it deflates, and then automatically it sort of all goes back into the balloon for next time after a few moments, after a minute or two. So pretty simple. Again, this procedure, if men need something like this, need to opt for something like this, is outpatient. Small incisions just in the underneath kind of the taint area, just put that in. Now, we usually, since we have to do our dissection around the urethra to get that in, we advise, we don't let it, let me put it this way. After the surgery, you don't walk out and you're like good to go, totally dry. We usually have folks wait 4 to 6 weeks, usually the full 6 weeks, just to let it all heal effectively and not put any stress on the urethra. And then you come in and we activate it in the office, and you're good to go. So obviously patients are really happy with this, especially if you go from, 20 pads a day, or you're leaking all over the place, and then suddenly you're pretty much dry. You can see why that people be pretty satisfied with that. Again, insurance generally covers this, and Medicare covers it, VA covers it, the same as the implant. Let me skip through some of this stuff. Yeah, and I kind of already said all this, but it basically, in my mind, restores a more normal way of going to the bathroom, as opposed to dealing with leaking and pads and all this stuff. So it can be really good. I think that's the end of my slide. So kind of rip through that, but happy to take questions now about anything.
Yes, we have a couple submitted or pre-submitted questions when I get to first, if that's okay.
Yeah.
So, a gentleman who had prostate cancer, sounds like over a decade ago, and has been experiencing erectile dysfunction since, wondered if, because so much time has passed, if he's still able to get that treated, his ED.
Yeah, I mean, I kind of mentioned this before. So, after prostate cancer surgery, your best window for recovery of, normal erections is in that first year. And I'm pretty aggressive on penile rehabilitation, and I'll talk about, I guess, now what that means. But basically, daily Cialis, so getting blood flow down to the penis, and then adding on Viagra too, if that's not working. So you're taking both of those things. The Viagra is as needed, so to get erections, and then adding on injections. Because basically, in that first year after treatment, I want men to get at least a couple erections a week, like minimum. Also doing vacuum device, so stretching out that tissue every day, 15 minutes. I think a lot of it's, on the when you get a diagnosis of prostate cancer, and then you're very focused on the treatment, and that makes sense. But prostate cancer is such a curable thing that really I try to tell guys up front that we really need to be focusing on, you're going to get better from this. We need to start thinking about your erections too, because like that's going to matter to you in a couple of years, and you'll be. But anyway, I guess my point is, There are therapies. The further out you get from the surgery, though, it gets a little trickier. And I would say most men, if they're not getting erections at 1 to 2 years, and especially if like the injections now are not working, they usually do really well with with that surgery I'd mentioned before, the penile implant. That'll fix the problem and get the erections back.
Thank you. Now, there's a question about incontinence that was submitted beforehand. So, gentleman said that he notices the biggest difference at night with incontinence. It's worse. So, wants to know, is there any particular reason that in the evening his incontinence seems to be worse than during the day or in the morning?
Yeah, that is so common. Generally speaking, it's because everything just relax. During the day, you've learned to do these Kegel exercises, your muscle tone is tight, you're thinking about it. At night, as you know, everybody knows, everything relaxes. So a lot of men say they're still having issues at night. Um, the, it depends how bad it is, obviously, but one like kind of solution to consider if they haven't considered this before is dehydration a little bit before bed, and the magic number seems to be about 4 hours. So if you go to bed at 10 p.m., I'm just making this up, then at 6 p.m., no more fluids, like no water, none of that stuff. Make sure that you empty all the way before you go to bed and try to avoid that. But yeah, that is a tricky problem.
Okay, so we got a question about high PSAs. Are high PSAs correlated or causal of erectile dysfunction?
That's a good question. No, a PSA in and of itself does not lead to erectile dysfunction. Just for some background info, like what is PSA? What is all that? PSA stands for prostate specific antigen. So basically, it's a protein. And actually, it's normal. Like it's a normal thing to have. It's a protein that helps liquefy semen, actually, and amongst other things. So you need PSA. But we use it as a surrogate marker for prostate cancer because um, when you have something disrupting the architecture of the prostate, like a cancer, now rather than just a little bit of PSA just kind of falling out by itself, the prostate, now kind of like the doors open. So all this PSA is leaking into the bloodstream. And that's how we track it. PSA in and of itself, though, does not cause any problems, like for what it is. Like the molecule doesn't wreak any havoc. And it's really not even a perfect test for prostate cancer, as anyone who's had this conversation before. There's lots of reasons that can go up: infections, having a big prostate, just getting older. If you had sex the day before you got your PSA taken, for sure it's going to be higher than if you didn't. So anyway, yeah.
Now, there's a question about TV ads, and specifically, do the TV ads about testosterone supplements do these supplements work, and are they safe? Are they potentially increasing my risk of cancer?
Yeah, that's a great question. I guess the first thing I'll say about that is there's been studies on supplements specifically, like analyzing what's in them. And unfortunately, like the overwhelming majority of these like men's booster one-a-day things don't really have anything good inside of them that would be helpful for your testosterone. Like they don't have testosterone in it. Now, are there supplements that can sort of help? Yeah, there actually are some. There is some data, like things like ashwagandha, for example, like 600 milligrams a day, that can help improve your testosterone a little bit. Not a crazy amount, but like anyway. But a lot of that stuff I think is just a money grab. Looking for solutions. Like I think for men that need testosterone supplementation, then the answer is like we should talk about testosterone replacement therapy, or lifestyle changes for sure. Like 4 hours of moderate exercise a week increases your testosterone, weight loss does. As far as the safety goes, all that stuff is unregulated. So, I have a lot of guys that take that stuff and they're fine. So generally, I would say it's safe, but it's not like there's a regulating body that says what's going into those things. So it's hard to say.
So there's a gentleman who had his prostate removed and then had radiation following. It's been
Mhm.
7 years with a PSA of zero, but still needs 2 pads a day.
Yeah.
Hasn't been consistent with Kegels. but asked, would a very disciplined exercise routine help?
For sure. In fact, I always encourage guys to do that first. I don't think that the playbook should be, oh, you have leakage, you get surgery. Because a very disciplined regimen for sure. I mean, your sphincter muscles are like any other muscle. It's like if you haven't been using them or working them out, they're not going to be robust. It's sort of like if you went to the gym and say you used to be able to bench 225, for 6 reps or something. If you don't go to the gym for 6 months, what's going to happen? I mean, you're not going to put up 6 reps of 225. It's not going to happen. But it's the same idea. So I do think so. I do think though, it's not a bad idea to have in that situation to have a like pelvic floor physical therapist like check in to make sure that you're doing the exercise correctly. Because you don't want to be like, spinning your wheels in the wrong direction. I don't think that is worth your effort.
Now, apart from just Kegels, are there other exercises that help improve bladder leakage?
There are, and I'm not going to pretend to be a physical therapist, but I know they do like reverse Kegels and they do like biofeedback, and they do a lot of things where they kind of feel around as you're doing exercises and try to get you to focus on certain muscle groups as you're clenching and doing that. And I can't even speak too intense about that because I'm not a pelvic floor physical therapist. But just from my own perspective, I have guys that go do that and they come back and they're a lot better than they were before. So whatever is happening. And the good news actually in Boise, Meridian, Namp, all that stuff, there's a lot of really good pelvic floor physical therapists. In fact, I feel like we have a surplus of them here compared to other places that I've lived, and they don't have insane wait lists like other places that I've lived. So I'm fully support at least seeing one.
So this person said, I've heard the penile implant is incredibly painful. Is this true?
So I think historically it was. Now, I would say most of my patients don't experience that much pain. And I think a lot of it has to do with what we know about pain prevention around the time of surgery. Maybe not just specific to penile implant, but in surgery general. So just for example, all my patients that I do this for, they get pre-medicated with pain meds before they even go to the OR. So gabapentin, which is if you're diabetic, you know what that is. Something called celecoxib and a whopping dose of Tylenol. There's data that just doing that even like in the morning of before you even wheel back, you've already started to help the process. I then do, we didn't talk about this at all, but I do 3 separate nerve blocks in the operating room so that you don't wake up with pain. One of them is something called an artificial erection, which is helpful for other reasons too. I can see if there's any curvature of the penis, but I use lidocaine, so the whole penis gets numb from doing that. And then I do a block that's called a crural block down deep where the penis kind of curves down into the pelvis. I numb that area. And then I also do a pudendal nerve block so that which is what kind of gets the scrotal area and kind of numbs everything up. So most of my patients wake up pretty good. In fact, I've had a few patients that wake up too good and then they go home and they're walking around too much and they come in the next day and they're more swollen. Because I tell them, you're going to feel okay, but I really just want you to lay down, lay down, ice. But yeah, so and obviously pain tolerances are different for everybody, but on the whole, most guys do pretty good.
Thank you. Question about the pump and where can somebody get a pump? And I know there's some that are more not costume, but there's high grade ones and lower grade ones. So where does somebody get a good one?
Yeah, that's a great question. It's always tricky when I talk to guys about this. Because if you go on Amazon, you can get like a $15 pump. It's not going to work very well. I usually direct people to 2 places that I trust. One is the Urology Health Store. That's a website, Urology Health Store. They sell high quality stuff. And if you're a patient with either anyone in our practice, Idaho Urologic Institute, or anywhere, but at Idaho Urologic Institute, we actually stock these things too. So we have vacuum erection devices and we only stock the good ones. So realistically, if you're looking to get a good pump, you're probably going to spend about $200 for a nice one. Some of them are a little nicer than that. You can get a $300 one. In my mind though, that one is the difference is that it's automated. So rather than physically pumping something, it's just a button, it's battery powered. Both are fine. But I would say you're looking at about $200 if you want to get a good one. And Urology Health Store or our office has them too.
Thank you. So, gentleman is doing PRT, testosterone replacement, and has a level of 1600. The question is very high testosterone dangerous for erectile dysfunction or erectile function?
Hmm. That's a good question. So just wind that back a little bit. There was a randomized control trial that came out, I think now a year ago. It's the best one we've ever had on testosterone replacement. And what we found was that testosterone doesn't necessarily, it was kind of shocking actually, doesn't necessarily help with erections. So we have people, so, and I do see this clinically. I have guys with a testosterone of 55 and they have erections. I have guys with a testosterone of 1,000 and they don't have erections. I think, so it's not related one to one. Now, where the crossover sort of happens is like if your testosterone's super low, your libido is definitely going to be low. If your libido is low, for sure, you may not have good erection. So there's like this like interplay. But on the whole, in this trial of like 5,000 guys, it did not seem correlated that the testosterone level led to good erections. Like I said earlier, you do need a certain level of testosterone that's been shown for the pills to be more effective, but just like on its own, it doesn't seem so. But I guess my point to answer your question is I don't think a level of 1600 will hurt your erections necessarily. There's no like impacts on that specifically. I do think at a level like that, the biggest concern for me would be kidney problems potentially and something called polycythemia where your blood gets too thick. Because there really is no data about men that have a sustained level over 1,000 over many years. So we actually have no idea what to expect for men who keep their testosterone or their provider keeps their testosterone that high for like decades. Um, most of the studies were done in men with a testosterone between 300 and 700. And we know that that is safe. So it's, you could extrapolate to over 1,000, but we don't actually have that data. It just doesn't exist. That trial's never been done.
Thank you. So, how much does alcohol cause leakage potentially, and especially at night?
That's a good question. I mean, if you're already prone to leakage, like if you've had a prostatectomy and you're already leaking, then for sure you're going to leak more. I mean, as anybody who's had a few beers knows, if you the more alcohol you have, the more urine you're going to make. It's a diuretic, and you'll pee a lot. So if you're just asleep and you already are prone to leakage, you're definitely going to leak more with if you have a few beers before you go to bed. That's why I mentioned before, like avoiding alcohol before bed, not having caffeine in the I mean, I didn't say this, but having not having caffeine in the afternoon and dehydrating before bed for guys that have leakage at night, super important, like 4 hours before bed.
So, there's a question. Is there a procedure to keep the scar tissue from closing up the urethra after surgery? Currently, I have to catheterize once a week to keep it open.
Yeah. Yes, that's the surgery that I actually don't do. One of my partners is more focused on stuff like that. That surgery is called a urethroplasty. I obviously don't know the nature of what surgery happened, but it sounds like what they have is a urethral stricture, and that's basically, as you can imagine, just a narrowing of the urethra, or the hole that we all pee through. And so, generally speaking, to fix that, you have to do a urethroplasty, where you basically either cut out the scar tissue and attach the good stuff, or we lay a graft, if that's not possible, lay a graft from, anyway, we lay a graft in there to expand the lumen, so the hole, so there's more to pee through. But yeah, there is a surgery for that.
Can a person who has had RARP, I don't know if it's a radical, or have an orgasm, and is it safe?
Like a radical or a robotic radical prostatectomy.
Guessing.
Yes. Yeah, they orgasm. I think the biggest thing that and hopefully men hear this before they get surgery, but one of the biggest changes is after a prostatectomy, when you ejaculate, there's not going to be any fluid that comes out. You'll orgasm still, but you won't have semen that comes out because your prostate's been removed, the seminal vesicles are gone, the vas has been cut, so there's no fluid coming out. but yes, you can still orgasm.
This may be a bonus question. My penis goes straight up toward my belly button during an erection. Is that normal?
Yeah, I mean, if it's curved like straight back towards the belly button, like if it's just like straight up like this, that's totally fine. But if you're telling me it's like a banana backwards to the belly button, that's definitely not normal. That would probably be Peyronie's disease. That obviously would make penetration super difficult if it's not pointing straight. So that would be something I would talk to guys about all the options to fix that because clearly that's not going to be helpful.
So, in relation to erections, is it more important for someone to have free testosterone than total testosterone or a high level there? And what role does nitric oxide play in creating erections?
Yeah. And I'll say that again, like the kind of surprising finding from that big randomized control trial was it seemed that the testosterone did not correlate well with erections. Like guys with really high testosterone, they did not have better erections than, or say they had better erections than men that didn't. So it's hard to say from what data we have. Free testosterone is the active component of testosterone in our bodies. Um, Usually it's like a reflection of the total. So like if you have a higher total, you're going to have a higher free. But that is one of the most frustrating things because there's all this data online about free testosterone on kind of like bro science sort of forums. The problem is we don't have anything that's like specifically able to target free testosterone. There are certain pathways to try to get it up though for men that are like for let's say I have a guy that his testosterone is relatively normal, but his free is super low and he feels terrible, even though quote unquote his testosterone is normal, his total. There are different ways to try to get it higher to see if they feel better. And basically there's two that work. One is just like super supplementing their testosterone, so getting it in the upper echelon of normal, so in like 900s, try to drag the free a little higher. The other way is that I think maybe is better is there's a medication called Kysotrex, which is like an oral testosterone, and that's been shown to increase the free better than other forms of testosterone. So that's something I talk to guys about.
Another testosterone related question. Here's a question from a woman. My sexual partner has been diagnosed with low testosterone. Sometimes he gets an erection, but does not have an orgasm.
Mm.
I would love for him to have one. What's going on here?
Yeah, that's a common thing too. So hormonal imbalances for sure. I treat a lot of guys for what's called anorgasmia. And there are definitely treatments for this. Most of this is like medication related, but definitely the first thing to do is to normalize the testosterone. We know very clearly that a low testosterone is going to lead to worse orgasms. So for that sort of patient, I would say normalize the testosterone. And if we're still having trouble with orgasm, I would kind of talk to them about all the different medications we can do to try to boost that. But that's a treatable problem for sure.
So I've got one last question here. We'll put last call in. This person's seeing ads for pills that combine Viagra and Cialis.
Yeah.
Do you recommend these pills?
What's that called? Blue Chew. So that's interesting. I do think that a combination of Cialis and Viagra is great. There's data that combination therapy worked well. I don't love how that's being marketed though, because it's not utilizing I don't think it's utilizing those two drugs in the best way. It feels very like, oh, we have these two things, here you go. When I have patients that I'm doing combination therapy, like Cialis and Viagra, that's what that pill is. I have them separate it because they're very different drugs. That's why I don't think taking them at the same time is beneficial. Like, for example, Cialis is in your system for 17 hours. And in my mind, that why that works when you combine with Viagra is it sort of primes the pump, so to speak. It gets blood down into the area so that rather from having to go from 0% to 100% when the moment rises, you're like hovering around 45, 50. And then later in the day, when you want to get an erection, you can take sildenafil, Viagra, and that medication works a lot faster than tadalafil does. So I think I guess to summarize that, the combination is good. I don't like how they've combined it into one pill because I think you're not getting the benefit of that combination. You're not getting the kind of benefits of the Cialis that take a little longer to get in your system and kind of help for a longer period, if that makes sense. I think they're just trying to make money on the combo.
Thank you for that explanation. Good question came in. Um, Before trying to raise testosterone, should we be tested for prostate cancer?
Yeah. I guess what I'd say is like before I would offer anybody, well, take that back. For men over the age of 40 who have not ever had a PSA and they're wanting to start testosterone, I definitely check that. And any guy who's on testosterone replacement therapy, I do check that. I have had patients where we were monitoring their PSA and suddenly it went up while they were on testosterone, did a biopsy, and they had prostate cancer. So that can happen. But yeah, generally speaking, that's something we monitor. We know that testosterone in and of itself does not cause prostate cancer. But the data from that is mostly people who had their starting PSA being less than 3. So any patient that comes to me who wants testosterone replacement therapy, um, if their starting PSA that I screened for in men over 40 is higher than 3, that makes me a little more cautious before I start their testosterone. Or I just monitor very closely. But that's, yeah, there's some nuance to that.
There's a question that I don't understand here, and I'll ask the person to clarify. It says, of three causes mentioned were medications, are there any that are more likely to cause issues? So not understanding the context there. But I will ask a different question unless you understand what they're asking.
Maybe
Um,
that's like what medications are more likely to cause problems. I mean, the antidepressants, people on chronic pain medications, for back pain, oxycodone, stuff like that. Beta blockers, like for your heart. Some people even think that blood pressure meds can lead to problems.
Thank you. Okay, you got that. If somebody wants to get a hold of you, Dr. Muncey, what's the best way to do that?
Just call the office, I suppose, and ask that you'd like to see me. But yeah, I work at Idaho Urologic Institute, and I see new people, and I'm taking new patients. So if don't have a super, well, I don't know, but not super long wait list. So yeah, happy to see anybody.
One more question sneaked in. How does an implant adjust for different sizes of erections? Is it one size fits all?
Great question. So um, it's not one size fits all. Obviously, everybody's penis is different. So basically, um, during the surgery, I would measure the whole length of the penis down to the pubic bone. So the part of your penis you don't even see, like the part that goes deep down inside of you, all the way to the head of the penis. I measure that, and so I put in the biggest device I possibly can, but not oversizing you, because that actually leads to other problems. And one thing that wasn't asked, but it's a common thing, is like, well, before this started happening to me, before the erectile dysfunction, before the Peyronie's disease, before the prostatectomy, my penis used to be, however big. I feel like I've lost length. The implant itself actually helps stretch out some the tissue. And so a lot of my guys, after surgery, maybe as many pumps as they can get into the implant is like 7 or 8, week 4. But if you look out a year, they can get like 20 pumps in. And so, they've stretched it a lot more. They can get more length. And most guys will be like, yeah, I'm like 80, 90% back after a year to what I was before. And there's other ways that I talk to men about inflating the implant in your penis every day for the first year after the surgery to help stretch things out as much as you possibly can, because that's been shown to help reclaim a lot of length. So even when you're not having sex, just like inflating it as much as you can, leaving it that way for 10 minutes, and then deflating it.
Thank you. So that concludes the Q&A portion of tonight's presentation. Dr. Muncey, it's November. You took a lot of time out of your evening after a very long day to be with us tonight, and I want to thank you for all the information you shared and all the great answers to the questions that you provided. For everyone's knowledge, we will be sending out an email tomorrow with the recording link to tonight's presentation and the number to the office. that Dr. Muncey mentioned. I want to leave floor with you for any final comments you have for people still in attendance.
Oh, well, thanks for coming, guys. I like talking about men's health. I try to do this every few months or so. Just 'cause I think it's a space where a lot of guys don't have anyone to talk to about it, or it's just hard. Sometimes it's hard to talk about this stuff. So I'm happy to do this, and if anybody has other questions, happy to see you in the office for sure. So I appreciate you all coming out.
This concludes tonight's Men's Health webinar. Thank you, everyone, and good night. And in a couple minutes, so I will hit start webinar at the hour,
Okay.
and then uh, people start signing in. We've already got, looks like 34 people in the waiting room.
Oh, wow.
And then at the hour more, we'll keep joining. So I'll wait like 20 seconds. I'll do a short intro of you,
Okay.
and then hand it over to you.
Cool. Sounds good. And then they're all muted, right? Like I'm not going to hear them chattering.
No, they won't be able to talk for in their videos off. I, we tried that. It's not a good system.
No.
It really, with the older crowd, because inevitably, like people talk to their partners, radio's not like there's just
Yeah. No, I know. That's how in residency during COVID, we had a lot of like Zoom meetings and always be like, hey, who's got their, who's not muted? Something's going off. And
yeah.
so I get it.
I'll turn my video off because no one needs to see my face. But yours stay on. You look good.
Got my setup.
All right, so I'm gonna hit start here and then wait like 20 seconds, and then um, we'll introduce you.
Okay.
People logging in here.
That's good.
Still got people trickling in here. More seconds.